Thank you, respected chairpersons. At the very outset, a big thank you to the organizers having given me this wonderful opportunity to interact with you. As correctly pointed out by the honorable chairperson, that we've thought of that glucagon and insulin are probably two sides of the same coin. But just like in Sholay, both the sides of the coin are actually doing the same thing. When you talk about either insulin or glucagon, both of them are the same side of the coin in the pathophysiology of the disease. So what was thought to be a unihormonal disease, that is type 2 diabetes, we now realize it is essentially a bihormonal disease where you have both an alpha cell dysfunction as well as a beta cell dysfunction, wherein you have deficiency of one and an excess of the other, which essentially leads to hyperglycemia and type 2 diabetes. So this is going to be my flow of talk. I'm going to talk a little bit about the glucagon physiology, the role of glucagon in type 2 diabetes, incretins and glucagon, and of course, the therapeutic implications of glucagon. So long ago, the islets of Langerhans were isolated, and what's important to know is if you look at the proportion of the alpha cells, it's almost similar to the amount of beta cell that you would normally have in the islets. And what's also important is you just can't simply have alpha cells and beta cells. You have to have a communication within the islets amongst the alpha and beta cells, because when you're doing, say, islet transplantation, this part is not taken care of. That's the interconnection between the alpha and the beta cells. So a little bit about the basic physiology. There's a gene which is the pre-proglucagon gene, which is spliced into numerous products, including glucagon and GLP-1. And glucagon receptors are found in numerous areas, including the liver and the brain, apart from pancreas, heart, and kidney. So if you look at the very basic of how does glucagon get secreted, these are probably the most important stimulants. And what's important is this huge amount of paracrine signaling. Particularly when you're talking about, say, SGLT2 inhibitors and hyperglucagonemia, it's probably more of a paracrine effect rather than a generalized endocrine effect of the SGLT2 inhibitors, which actually cause increase in glucagon. Now, our respected chairperson was talking about, that we've only recently understood how important glucagon is, but if you go back into medical literature, this is New England Journal of Medicine 1970. That's when they first thought, the alpha cells might be having some role in the pathophysiology of diabetes, which obviously, because unless and until you have a therapeutic target, we don't talk about things. Researchers don't talk about things because it's not fashionable to talk about things which does not have clinical implication. And when you're talking about alpha cell dysfunction, there is either an absolute or a relative increase of glucagon in the fasting and the postprandial state. There is lack of glucagon-induced suppression in hyperglycemic condition, and there might be impaired secretory response of alpha cells to low glucose levels. And in the postprandial state, the hyperglycemia could well be having a major contribution by hyperglucagonemia. And when we talk about the GLP-1 analogs or the GIP or the GLP-2, they all suppress the glucose levels by lowering the glucagon levels. That's the predominant mechanism of action. Now, I would like all of you to concentrate only on this one slide for at least a minute or so. Conventionally, what have we been taught? In type 2 diabetes, you have beta cells, and we've been taught about beta cell death. So over a period of time, the beta cells will die out. The beta cell, in this particular research, which is now being supported by a lot of other research, is now clear that the beta cells don't die in type 2 diabetes. They get transformed into something else. So it's not simple cell death. It is shown that there is something called de-differentiation. So the beta cell gets de-differentiated into an alpha cell. Now, why is that important? Because now if you can find a therapeutic mechanism by which you can do a de-differentiation of the alpha cell into a beta cell, you might be able to find a cure or management for type 2 diabetes. This is a seminal publication from New England Journal of Medicine, and there is a lot of pathways which we can talk about, including the FOXO pathway, by which actually in animal models the alpha cell has been utilized to re-differentiate into a beta cell. Now, in type 2 diabetes, when you give someone GLP-1, the glucose level goes down, the insulin level goes up, but interestingly, see down there, the glucagon level goes down. So glucagon has a very important part in the pathophysiology of diabetes, and this is again shown in a graphical manner of what happens to the GIP. When you give GIP infusion, you can see the insulin going one way and you can see the glucagon going down the other way. And what's also important is, in type 1 diabetes, what do we say? It's only the beta cell that's gone, and that's the reason why you have type 1 diabetes. This is a mouse model study in which they show that if you knock out the glucagon receptors and then you take out the beta cells in the mice, you no longer develop type 1 diabetes. So it's not just a simple lack of beta cell and insulin that will cause diabetes. Along with that, you will have to have something wrong with the alpha cell in terms of its function for diabetes to happen in the first place. So if you again now look at glucagon, we seem as if we are blaming that everything that glucagon does is bad. That means hyperglucagonemia is bad for you, right? But we've now realized that glucagon itself might be having some good effects as well. Now, why am I highlighting this? I will talk about it when I talk about the newer drugs that are coming, where we can probably use glucagon receptor agonist in management of type 2 diabetes. However paradoxical it might sound, glucagon receptor agonism also might have some beneficial effect. And that beneficial effect is predominantly by increasing energy expenditure. Now, in a hypoglycemic situation, glucagon has certain role. In the pathophysiology of hypoglycemic situation, there is some certain other role. So, in a hyperglycemic milieu, when it happens because of hyperglucagonemia. There might be weight loss, and there might be some benefit in case of NAFLD. In hypoglycemic state, the hormone that prevents you from dying is probably glucagon, because it causes recovery from hypoglycemia, and glucagon is used for management of hypoglycemia. So this is the positive thing that I was talking about. Glucagon increases energy metabolism and expenditure and might cause weight loss. And that's probably the mechanism by which partially the GLP-1 receptor analogs actually work. In terms of what happens in NASH and NAFLD, we don't know what's the cause and what's the effect, but probably hyperglucagonemia is actually a beneficial thing that happens in management of NAFLD and NASH. So that glucagon pathway will probably increase expenditure of some of the metabolites that accumulate in the liver. That is something which might be beneficial. So glucagon benefit in NAFLD, it can cause weight loss, lipid metabolism can be modified, and general metabolic state might also be modified. Glucagon in hypoglycemia, you're all aware of that, if you do not have glucagon, endogenous glucagon levels, recovery from hypoglycemia is going to be delayed, and the hyperglycemic response of counter-regulatory hormones that occurs, whether it's the growth hormone, whether it's the cortisol, it's all actually mediated through the glucagon pathway. And in individuals where you have an early loss of glucagon response, that might lead to hypoglycemia unawareness and severe hypoglycemia, which you might not be able to manage. So if I can again summarize glucagon secretion abnormalities, it will be a problem if you have high glucagon levels, as in type 1 diabetes, advanced type 2 diabetes, or in the pathophysiology of diabetic ketoacidosis. However, the paradoxical glucagon response to meal might actually lead to postprandial hyperglycemia. So I'll skip some of the slides because I just want to concentrate on the therapy areas as well. Now, I've already talked about how the alpha cells are equipped to adapt and survive in metabolic stress. Therefore, in type 2 diabetes, the beta cell becomes an alpha cell and stays like that. Could this lead to preserved alpha cell and thus hyperglucagonemia in type 2 diabetes? We don't know, and whether we can go for re-differentiation. In terms of the NAFLD, I've already talked about that there might be hyperglucagonemia, but glucagon itself might actually be good for NAFLD for management. So is it possible that you are having NAFLD where the glucagon levels are high and yet you are having the bad metabolic effects? That's probably because just like you have insulin resistance, in the pathophysiology of NAFLD you might have glucagon resistance. So what about glucagon and diabetes therapy? Let us look at each of the drugs, just one-liners, because I have only about 2.5 more minutes to finish. Metformin suppresses hepatic glucagon signaling by decreasing production of cyclic AMP. That's probably one of the most important mechanisms by which this mystery drug metformin actually works. If you talk about insulin and sulfonylureas, they inhibit glucagon secretion. If you look at glimepiride, in one of the studies it was shown that there might be even weight loss with glimepiride, and one of the postulated mechanism is probably through the glucagon pathway. Pioglitazone and the TZDs do not have any effect on glucagon. Amylin mimetics, that is pramlintide, is a drug which is not used in India but used elsewhere, decreases glucagon. We all know about the DPP-4 inhibitors and the GLP-1s. I think I will not waste time because you would have had a million talks on GLP-1s and DPP-4 inhibitors. Just a few words about it. That DPP-4 inhibitors versus sulfonylureas, if you particularly compare, the glucagon response is much better modulated by the DPP-4 inhibitors compared to sulfonylureas, in spite of possible similar glycemic control. In terms of the GLP-1 analogs, they also suppress the glucagon level, and that's one of the most important mechanisms of action. And even the GLP-1s, the mechanism of weight loss is probably through the glucagon pathway. In terms of the SGLT2 inhibitors, we are all aware that it causes hyperglucagonemia, and that results in two things. Number one, 50% of the clinical efficacy of SGLT2 inhibitors is blunted because of the hyperglucagonemia. And secondly, it is the cause why you have euglycemic ketoacidosis in type 2 diabetes when you use glucagon. Sorry, I can't show you the pathway. Now, when you are talking about newer drugs that are going to work through novel glucagon pathway, I'll just list 3 drugs. Now, we have been using DPP-4 inhibitors and we have been using GLP-1 analogs. But there are now other injectable agents which you can use. And of them, the second and the third are probably going to be very important. The first is already has got a name now. It's called tirzepatide. It's a twin creatine which uses both combination of GLP-1 and GIP. This is a product of Eli Lilly, which is already undergoing clinical trials in India as well, which shows huge amount of HbA1c reduction of 2.4% and with great weight loss. The second is a molecule which AstraZeneca is actually developing right now. It's called codutide. It's an oxyntomodulin-like peptide which has got a glucagon receptor agonist property in addition to a GLP-1 property. So now you know, if you have a molecule which will stimulate the glucagon receptor and increase energy expenditure and cause weight loss, whereas the GLP-1 analog will inhibit the bad effects of glucagon, then you are having a combined effect where the good bit of glucagon is utilized and the bad bit of the glucagon is suppressed. The third is another molecule which the Japanese people are under development, where they are using a drug which is a glucagon agonist, a GLP-1 antagonist, and a GIP antagonist. So 3 new drugs in pipeline. And finally, this is the study that I was trying to talk about. I've already talked about in type 2 diabetes, you have de-differentiation of beta cell to alpha cell. This is one very early report in mouse model study where they have de-differentiated the beta cell back into the alpha cell back into a beta cell and cured diabetes. So what about glucagon and hypoglycemia? Just quick words, because this is something that you and I use in clinical practice. You have 2 commercially available glucagon kits, and it takes about 10 to 15 minutes to act. Probably I should have given it at the beginning of the talk so that you did not develop hypoglycemia, and the effect lasts for about 30 minutes, and vomiting might occur because of the GLP-1 like effect of glucagon, and therefore you should keep the patient in the left lateral position because otherwise the patient might aspirate if you have somebody who has developed hypoglycemia. Recovery from a severe hypoglycemic episode depends on a lot of things. I'll talk about that. And there are certain signs and symptoms which may persist for several hours. These are situations where you have to be aware of. If somebody has hepatic dysfunction, if somebody is having alcohol for a long period of time, or has had a sulfonylurea, this is probably not going to work in terms of management of hypoglycemia. And now, instead of an injectable glucagon, FDA has now even approved a nasal glucagon. So you have a patient who's developed hypoglycemia, you can give a nasal puff of glucagon and reverse the hypoglycemia. And now we have another stable solution, because the other glucagon injection that I talked about, there's a lot of problems in storage of that particular glucagon and also very short half-life. So shelf life. So you can't keep the glucagon keep buying every 6 months, when am I going to have a severe hypoglycemia? This is going to have a much longer shelf life, this particular glucagon analog, which is called dasiglucagon. So I've already highlighted the positives and the negatives, both in hyperglycemia and hypoglycemia, and I shall stop there. Thank you very much.
Thank you, Dr. Ghosh. Very nice presentation. So glucagon suppression is becoming the newer therapy in the management of diabetes mellitus. Any questions from the audience? Hello, Mike, please.
Yes, sir. Agreed, sir. Sir, I was given 17 minutes to speak, then it came down to 13, and today I saw it was 10. Because so I actually had to keep on cutting down on various aspects. It's not possible to talk about, but definitely there are studies to show that it can be cardioprotective as well. Agreed, sir.
No, this is important in the sense, SGLT2 inhibitors practically have...
So that's one of the postulated mechanisms.
Yes,
agreed.
Just one comment. When we differentiate, we go to the progenitor cell.
Right. Right. Ma'am, there are five different cell differentiating transcript molecules. Now, depending on certain pathophysiological processes, which I also don't understand very well, there's a molecule called FOXO1.
Fibroblasts and others.
FOXO1. That's probably the key molecule which because all of the cells, even in the pancreas, in the islet cell, are in a progenitor state. Because we were taught as if you develop beta cell at birth or at the time of birth, and then you no longer grow any new beta cells. That is not true. There is cell renewal of beta cells all through the life in all individuals. Possibly the rate of renewal goes down. So we have progenitor cells within the pancreas itself. So what will happen, whether it will go to the pathway of the alpha cell or whether it will go to the pathway of beta cell, when this regeneration is happening.
So from de-differentiating to the progenitor, they again have to differentiate into that.
Yes.
Thank you.